Thank you to the NCCA for inviting me to speak here, and we'll go ahead and get started here. Today we're going to talk about what story do your records tell. And I think that it's really important to understand for everybody, all practices to understand, all providers, that when we're talking about healthcare, when we're talking about our documentation, when we're talking about everything we do tells a story. And the concept that I want to try and get across today is that when we're talking about our documentation, it's like a book. If you think of your documentation like a book, each date of service is going to be a chapter in that book. You're going to have your initial opening chapters, and then some chapters are going to be bigger than other ones, but it's going to tell a story, and that story is going to be a natural progression. And the other concept that we're going to talk about is before you can tell a story, you really should do an outline of that story, and that's going to be your treatment plan or care plan. So we're going to go through that today. I'm going to talk about care plans. I'm going to talk about telling the story. And it's really important for everybody to understand that it's not just our documentation that tells the story. It's everything we do in practice that tells the story. For example, a cervical sprain strain. If you submit a claim to a carrier and you indicate that the patient has a cervical sprain strain, to that carrier, it's going to indicate that the patient has a whiplash injury. And they're going to automatically think that that patient was in some sort of automobile accident. And oftentimes they'll actually send the patient a questionnaire. And so we want to make sure that we understand that our diagnosis codes tell a story. When we bill for our initial evaluations or our subsequent evaluations, the level we use indicates the severity of that patient's condition. And if we're billing a level 1 evaluation management code, we're actually indicating that that problem is likely to self-resolve, and yet if we go on to treat the patient for multiple visits after that, we might be telling a mixed story. So it's important to understand that the codes we use tell a story. The modifier, 59 modifier, very common modifier used in the coding in chiropractic, that indicates that a separate site or organ system was treated than the one we adjusted. So we want to make sure that we only use that modifier when necessary and only use a modifier when it's warranted. So we need to understand that. And then, of course, our fee schedule. We need to understand that the fees that we bill to the carriers, they tell a story. They tell the carriers how we value our services. And it's very important to understand and really realize how to properly set our fees. So those are all ways that we tell a story. So we have to understand that concept when we're in the healthcare arena, especially if we're dealing with third-party payers. Now, today's presentation, I am going to talk a little bit about the negative, okay? There's a lot of things going on in healthcare today, including audits, and I'm going to start off with that. I'm not going to spend a great deal of time on it, but I think it's important to understand what audits are about and what providers should be aware of. So we're going to go through that. Then we're going to talk about care plans. Again, that's the outline of the story that I mentioned, and it's really important to understand when to use them, how to make them, and so on. And so we're going to touch base on that. Then we're going to talk about telling the story, actually our documentation, our daily notes, and we're going to talk about a few pointers there. So why don't we go ahead and start with what's going on in the healthcare industry. And probably, if not all of you, realize that insurance is paying for less and less. Patient responsibility is increasing, and insurance responsibility is decreasing. And this line is constantly shifting. It seems like as time goes on, it just keeps on whittling down. We see co-payments on the rise, we see deductibles on the rise, and then we see our reimbursement on the decline. And this really happens to be, it's not only patient responsibility, it becomes practice responsibility, because we have to figure out how to offset that declining insurance reimbursement. The other thing is that the line is very clouded. It's really complex, and I like to use the analogy, if you call up an insurance company 3 times, you're probably going to get 4 different answers. So we really have to be good at understanding these benefits and stuff. So there's a lot of challenges out there right now for us, and unfortunately, this is just the way that it's going. And one of the things that is driving this is that healthcare spending is becoming just, it's huge. We're spending this was in 2008, $2.4 trillion. I hear we're going to be close to $3 trillion this year. So every year it's rising. The other thing is that we're spending over 17% of the gross domestic product on healthcare, and then of course 4.3 times the amount of healthcare is spent on healthcare than we are on national defense. And obviously we've had a lot of things going on with our defense, with the wars. So there's just a ton of money being spent out there. And the reason is that, well, not the reason, healthcare costs are going up. We've got the baby boomers. We don't have to talk about that. But what we do need to understand is that this spending is causing insurance companies, including the federal government, to really clamp down and save wherever they possibly can. One of those ways is that they found that for every $2 million they invest in fighting healthcare fraud, they're getting back about $17.3 million. So private carriers, they invest $2 million, they get back 17. That is good business. The Office of Inspector General, or OIG, for every dollar they spend, they're getting back close to $17. So it's really good business to fight fraud and abuse, okay? In 2008, they recovered, the OIG recovered $3.68 billion. It's said that they're going to be close to $9 billion this year. So that remains to be seen, but the point is that huge amounts of money. And in 2008, Blue Cross Blue Shield over $350 million, they're going to be close to $1 billion this year. So it's good business sense to fight fraud and abuse, okay? And what does that mean? Well, they're doing a lot of post-payment audits. So when they find out that it's good business to go through audit providers, it becomes really good from a business perspective. So that's why we're seeing a lot of these post-payment audits cropping up. I know there's been with Medicare, there's been with private payers for different issues. So we have to understand that our documentation is key to protecting us against that. But we also need to understand what are some of the things that carriers are looking for. Well, the primary thing that the carriers are looking for is money. I would say that probably everybody on this phone, fraud is not an issue. It comes down to simple business. If they can spend $1 and they're getting back 17, it makes business sense. So post-payment audits are about money, okay? Now, there's 3 main types of audits that I wanted to discuss today. I think it's really important for providers to understand what's out there and what they should be looking for. The first type of audit is a cert audit. And the cert audit is where a carrier asks for 1 or 2 dates of service, and they're just trying to make sure that there is it's error rate testing audit. And typically they're going to ask for a single date of service, and you send it in. I would strongly suggest if you get a request for a single date, don't just send in that date, because nobody can really tell if care is warranted or not unless there is backup to that date of service. So what I strongly recommend is going back to your last reevaluation and sending all those records in between so they get a picture. Again, everything's about telling the story, and if they can't tell the story from that single date, then you probably need to send in some additional information. But this is the most benign type of audit you're going to get. It doesn't require a lot of action on your part, other than you want to make sure and respond in the time frame requested. So that's the first type of audit. The next type of audit are commercial audits. This can include Medicare. I know there were some recent audits that Medicare instituted within the state of North Carolina. They actually went into other states as well. But commercial audits are where they request a group of patients or a larger number of patients. It can be between 5 and I've seen anywhere up to 225 different patients. And they're requesting a certain amount of data going back. Typically, they're looking for 6 months, a year, or so on. If you receive a request from for one of these, a carrier with this type of request, typically it's from the Financial Investigations Unit, the Claims Auditing Unit, the Special Investigations Unit. These are the types of audits where you really want to make sure and get a little help. Don't just go ahead and copy your records and send them in unless you are very confident about what you have. Typically, I recommend that a provider contacts someone that knows what they're doing and make sure that you don't send in too much information or too little information, because carriers use that to their advantage, not your advantage, depending on what you're sending. So it's very important to get some professional help, someone, a coder like myself who does a lot of this, or maybe a healthcare attorney. And if someone were to hire me, I would always get a healthcare attorney involved. These types of audits, you want to make sure that you protect yourself. It's about money, and you want to make sure and keep it. And I guarantee that the auditor on the other end has an attorney advising them, probably many different attorneys. So you want to be smart about that and get some professional guidance if you receive one of these commercial audits. There's a lot of them going around, and we just have to make sure that we do everything we can. Now, the last type of audit are RAC audits, or Recovery Audit Contractor audits. Now, these are Medicare-only audits, and Medicare, in its wisdom, decided that in order to really combat fraud and abuse, they were going to hire outside firms and pay them a percentage of whatever they can collect. So these firms are now going around the country, and there's 7 different firms throughout the country, and they are out there looking for overpayments, fraud and abuse, and so on. I have not seen these types of audits within the chiropractic community. Right now they're going after hospitals, large facilities. They're going after the money, of course, because they can get paid up to 12.5% for whatever they recover. So it can be very big business. The point is that this is a Medicare type audit. They can also be in the commercial audit category, but if we start to see some of those, I will certainly let the NCCA know, and I know you guys have a really good committee on keeping on top of all of the Medicare issues that are out there. So these are the types of audits that we need to be aware of. Again, I hate to focus on the negative, but I think it's really important for providers to understand. It's also important to understand who can be selected for an audit. Well, I can tell you if they're about money, they're not random. They're going to go after the people with the bigger practices, those that are making the more money, because, of course, they want to get as much money as they can. How is a practice selected for an audit? Typically, these are the top 5 ways that a practice is audited. I would say 90% of the time, provider profiling is the top way. Remember, everything we do tells a story, and it's very easy for carriers these days to simply go in, run a query of what kind of services you offer, how frequently you see patients, and so on, and compare you to the rest of your peers. And if you fall outside of your peers, that would be one way, or the most common way, of selecting you to be audited. Either you use a certain type of code, you use frequency, you see patients for significant periods of time, and standing outside or being having a different profile than your peers is not necessarily a bad thing, as long as you can back it up. And that's what we're really going to go through today, is making sure that what you bill can be backed up by what you document. We're going to key on some really important points here today. Other reasons for audits are complaints from patients. So one of the things that I always tell providers, if a patient complains, listen to them. You want to make sure that you try and answer their questions. Medicare patients especially, because they complain, they have to be investigated, and sometimes Medicare patients can be confused. They don't understand all of the intricacies of insurance. Well, I don't think very many people do. In any case, complaints from a former employee, advertising, and then, of course, submitting claims for family members or employees and so on. A lot of policies actually have clauses in them that you can't treat direct family members and so on, or for reimbursement. So we want to keep an eye on those things and understand that these are the top ways that we are selected for an audit. Okay, so now that we understand what's out there, what's going on in healthcare today, we also have an understanding for the types of things they're looking for. How can we protect ourselves? Okay, because you got to get paid, you got to do things. Unfortunately, documentation is what I call a necessary evil. You have to tell the story. Okay, care plans. This is where it all starts. Before you can write a book, before you can tell a story, you have to do an outline of the story. So it's really, really important to understand what a care plan is all about. I should also tell you that when it comes to care plans, this is probably the easiest and best way to give your documentation a boost. What do we mean when I talk about compliant care plans? And by the way, care plans, treatment plans, I use the term synonymously. So I think I like the term care plan much better than treatment plan. So what do I mean by compliant care plans? Well, this is something that I typically see. Chiropractic treatment plans, so that's 3 times a week for 4 weeks, 2 times for 6, 1 for 12. That's 4 exams, 36 adjustments, 12 modalities, 16 therapies. That would be $2,800. Oh, and by the way, I'm going to give you a discount because I like you. And that is not a treatment plan or a care plan. That is a treatment schedule. That is not what carriers are looking for. Why is a care plan so important? Well, first of all, it's federal law. Medicare requires that you have a treatment plan. Chiropractic is no exception to that. By the way, your board, they require that you have a plan of care for your patient prior to treating them. Insurance companies, they require a care plan. And by the way, they typically mimic the requirements of Medicare. So we're going to get into that a little bit, exactly what Medicare requires. And if you satisfy Medicare's requirements, then I can almost assure you that you will satisfy everybody else's requirements. So we're going to use them as the guidepost. And of course, today's patients demand them. The more that the patient is responsible for care, the more they want to see what are they going to owe? And the best way to do that is to have a care plan and lay it out for the patient. So everybody's looking for care plans. Why do insurance companies, why does Medicare find it so important? Well, from a carrier's perspective and from Medicare's perspective, it shows that you've gone through the decision-making process of how can you get this patient better, that you've taken the time to think through. How many of you have started treating a patient and pretty soon 6 months goes by and you're like, wow, I didn't realize I've been treating that patient for 6 months. I can tell you that when providers get an audit request and a request for records and they go back and they look back to see what they've done for the patients that were requested, often one of the most common things that I'll get is, holy cow, I didn't realize I've been seeing this patient for 2 years or 3 years. So having a care plan mapped out will help you keep on top of that. I think it's very important to understand that. So one of the other things that I think is most important is that carriers are targeting care plans or treatment plans right now. And I think a lot of it's due to this report filed back in 2009 by the Office of Inspector General. The OIG, or Office of Inspector General, they're like the policemen for Medicare. And they did a report on chiropractic payments. One of the main things they focused on was the treatment plans or care plans. It's common for chiropractors to have treatment plans that include frequency, duration, and goals, but they're often verbal and not documented. I rarely saw documentation of a plan which included frequency, duration, and goals and objective measures. While the guidelines are in the manual, they apparently have not been incorporated into the profession. So Medicare, or the OIG, created this report for Medicare, and then they sent this out to everybody. So everybody says, hey, by the way, guys, this is one of the weaknesses of the chiropractic community. So what do you think they're going to be looking at when you're audited? they're going to be looking for your care plans, a treatment plan. And the fact that they have it in their policies, that it's a requirement for federal law, means that you got to do it. So what do you have to do to create a good care plan? Well, what you're going to do and why. That is very important. The why is the most important thing. Chiropractors are very good at telling me what they've done. The why is oftentimes left out. It's not easily inferred, so you have to make sure that you identify why you plan on doing something, where you're going to do it to, and for how long. What's your plan? And we're going to get to a few more details here on that. Of course, the phases or stages of care. I think this is really, really important. Now, this is not a requirement of federal law, but you have to record it. It is a requirement for you to record goals, short-term and long-term goals. And when you go through and you start treating a patient, and you are going to adjust them all the way through care, guaranteed. The thing is, though, that the goals for the adjustment in the first week, I guarantee, are going to be different than the goals for the adjustment in the last week, short-term I'm talking about. So you want to make sure that you stage it out so you can show how those goals start to progress. And if you do that properly, you can really write a great treatment plan. Very, very important. And then, of course, you want to make sure that your treatment plan or care plan is a best-case scenario. You're not saying, oh, I'm going to have to see this patient for a year. Because if you write that down, I guarantee a carrier is going to say, forget about it. A year does not make sense. So always do it in a best-case scenario, and then the patient is going to respond as they respond, and you change it up on the fly. That's fine. But don't go out there thinking worst-case scenario, because most payers will not buy that. Okay. So what are some of the basics of our care plan? First of all, it's the outline of the story. I think we've talked about that. Best case scenario, 6 months, not acceptable. Keep them short and sweet to start. And patients can evolve over time. You can have a 1-week care plan if you want to. Just remember, at the end of that week, you need to update it if you continue seeing that patient. And care plans can change to fit the patient. That's okay. I also like the creation of templates. You're going to, when you see a patient for certain scenarios, you are probably going to do adjustment and have the same short-term goal for the adjustment for most patients. So if one of the things that I always recommend doing is to create templates. I'm going to talk, and after the next slide, I'm going to talk a little bit about how I would formulate and create a template. Now, what are some of the elements of a care plan? And this, by the way, is right out of federal law. What I recommend, or what I did, was I took the requirements from the Medicare Carriers Manual for chiropractic, and then I combined it with the requirements from the Code of Federal Regulations for outpatient rehabilitation. And what I found is that most payer policies have a requirement for treatment plans or care plans that lists all of these elements. And so by combining chiropractic, outpatient rehabilitation, you will have a very solid compliant care plan. So the first thing is your diagnosis. I always suggest writing it out. If you put down a number, numbers can be misinterpreted. So write it out. Remember, your documentation is a controlling aspect of reimbursement. So if the claim form, if a number is misstated on a claim form, you can always go back to your documentation to find out what it really was supposed to be and resubmit. So write it out. The second thing is specific procedures. I often ask providers, how many different types of therapeutic exercise are there? There's thousands. So if you just put down therapeutic exercise, is that being specific? Absolutely not. Manual therapy. If you just put down manual therapy, how is a provider payer to know what kind of manual therapy you perform? Was it trigger point therapy? Was it myofascial release? Actively, whatever the case may be. So get specific. I don't think you really have to put down specific techniques you use when it comes to CMT, but you can if you want to. Just keep in mind that you want to be consistent. And then, of course, your frequency, times per week, duration, and number of weeks. These are all things that you need to have in there. How many times per week, what's the frequency, the duration, and how many weeks are you going to continue with each specific procedure. And then, of course, your goals and rationales, long-term goals, things like I want the patient to be able to sit for 1 hour with no pain. That's more of a long-term goal. Short-term goals are reduce restriction, break up adhesions, increase strength, increase range of motion, things of that nature. And those can be assigned to specific procedures. The goals for your adjustment may be different than the goals for your therapeutic exercise. So keep that in mind. And then, of course, stages or phases. These can serve as benchmarks. Very, very important. And then, of course, you want to sign it. All of your documentation, every page in a patient's chart should be signed, whether electronically or manually signed, but you want to make sure and sign it. Another thing that's not on here that you may want to take a note of is that the Code of Federal Regulations states that you must update your treatment plan as often as necessary, but at least every 30 days. So if you're looking for a time frame for how frequently should I do my reevals, well, if you have to update your treatment plan based on the Code of Federal Regulations at least every 30 days, then you might want to think about 4 weeks for doing your reevaluations, because the only way that I know of to really update your treatment plan is to reevaluate that patient. Remember, think about your documentation backing up. Even if you don't get paid for that reevaluation, in my opinion, you should still be performing it. And you still should be documenting it and billing it to the carrier so they know that you're doing it. I've actually had auditors say, I don't see any reevaluations in here. And Medicare actually looks for those reevaluations. They want to see the comparisons to the initial evaluation. So even though you're not getting paid for it from the carrier, you should always be making sure and documenting it and billing for it. Okay, now, when creating these templates, I just want to take a step back and go through templates. What I always recommend to a provider is to think about how many stages of care that they're going through. How many stages do you think you have? 1, 2, 3. Maybe you have an initial intensive phase, then maybe a rehabilitative phase, and then maybe a corrective phase of care. And I'm just throwing some names out there. And in each of those phases, I would write down what specific procedures you do in each phase and write them all out, just the specific procedures. Therapeutic exercise consisting of blah, blah, blah. Then for each specific procedure, put down why you're doing it and write out the goals for each procedure you do at each stage of care. And then write down the frequency for each procedure, how many times per week, and so on. And pretty soon you're going to have each phase of care mapped out in a template format. Then when you go to write your treatment plan or care plan, you've got everything templated and mapped out for yourself, and you can simply plug it in to your treatment plan based on what that specific patient's requirements are. Now, of course, we're sponsored by PayDC. We have an automated way of doing that, but you can do it on paper very simply as well. So that's something that I strongly suggest doing. Really, by forcing you to sit down and think about that, providers really, at least the ones that I've worked with, said, wow, I've never really thought about the care like that, and it was really helpful to map it out, because then going forward, it's plug and chug. All right, so now that we've talked about the care plans, let's get into actually telling the story. So if you think about your documentation like a book, okay, Chapter 1 is your initial evaluation, okay, and that's the major chapter, one of the major chapters. You're doing your outline and so on. Let's take a look at what carriers, what kind of story do insurance companies typically like to see. And I apologize, I've got a little faux pas with this slide. But the first thing you're going to start with is your initial evaluation or your examination of that patient. And from a carrier's perspective, they want to see functional deficit after that. If there's no functional deficit, then you might have an issue. I've actually, in reviewing certain providers' documentation, some of the intake forms ask the question, what is the reason for your visit? Instead of what is your chief complaint? And often, I'll see some of the crazy answers to that. Like one I saw, my son is the doctor. That was the reason for that patient coming in. Or I received a coupon in the mail. Carriers that see that on the initial intake form might start to question all the care after that if that's the answer given. So you want to make sure that there is a chief complaint, a functional deficit identified if you're planning on getting reimbursed by a payer. The next thing that they expect to see is a care plan developed. After that, they typically expect to see some form of passive care. Patients coming in, they're going to be more in an intensive acute phase of care, and they're typically looking for passive type services to be provided. Passive services are where the patient is passively receiving. Adjustments, they are passive. Stim, traction, ultrasound, those are all where the patient has no active involvement in care. And that doesn't mean it has to all be passive. Maybe you're doing some stretching and so on. It can be a combination of passive and active type care. But typically, a carrier will take a look and want to see or will look for that passive care. Then a reevaluation, again, as often as necessary, at least every 30 days is when I would recommend doing those reevaluation, and then a transition to more active forms of care, getting that patient actively involved. If you read certain payer policies out there, I've actually seen where they will actually require the patient or look for and require the provider to get that patient in some sort of home exercise program. I'll bet that most of you do that. How many of you are documenting and actually billing for that home exercise program that you're putting the patient on? If you show them how to do that exercise in your office and whatever, that, again, it tells the story. But this is what they expect to see. Then the reevaluation again, and then a transition eventually to wellness or release them from care and so on. Now, I know this is more, this is just a basic flow, but this is typically what payers and carriers expect to see from providers. So keep that in mind. This is something that you're typically going to find. Now, when it comes to your daily documentation, you got to have that starting point. You have to have that initial evaluation, okay? And that initial evaluation is going to be your starting point. All other dates of service should really be a comparison of this baseline, all right? You don't have to reinvent the wheel every time. You do want to say, in comparison to the last visit, how that patient is progressing. Very, very important, okay? Measurable results. If you just say they're doing better, that's not measurable. If you identify how that patient, let's say you choose pain, if they were a 10, now they're a 9, and so on, that is something that is measurable. So you really want to try and focus in on measurable results. Status quo, patient doing better, those aren't measurable. And if you say, hey, patient's fine today, that might be a flag to the carrier to say, hey, well, if they're doing fine, then maybe they shouldn't be treated. So I would avoid those types of phrases if you plan on getting paid by a payer. And then, of course, you want to make sure that you are telling the story. You don't want to have a canned story. One of the kisses of death for documentation are to say the same thing over and over and over again. That makes for a pretty lousy story. So if you want to tell a good story, it's going to have ups and downs and highs and lows, and it's going to be based on that individual patient. You also want to make sure that you are not, that if you're using an EHR system, be careful of randomized text. Medicare has actually said that's a flag, and you want to make sure that one of the things that I've seen is that randomized text actually jumbles up the words and kind of says it differently, so it doesn't look like chapters in a book. It looks like individual stories, and it's very difficult to follow. Plus, often I see, where the subjective says patient exacerbated, hurt themselves doing this, and then in the assessment section it'll say something like patient doing much better. Well, that immediately from a carrier's perspective says, hey, something's wrong here. Why is it, what's going on? And they start to doubt the records. Also, some of the things that I've seen are, Mr. John Doe presented today with low back pain. She is, and so you get the genders mixed up. Be careful about all that stuff because that can actually make your documentation look worse. And so you want to make sure that you really understand how your system works if you're using an electronic health records. When it comes to subjective, don't just think pain scales, or don't just say pain, pain, pain. Pain is definitely a key indicator, but keep in mind that you want to identify other things. Like, for example, a patient can have pain at rest, but what about when they're moving? So one of the things that I recommend to providers is put pain at rest and then pain with motion. And that can be other ways that we can identify progress and show those measurements. How does the care relate to the patient's activities of daily living? When it comes to frequency, up to 50% of the day it's bothering the patient. And then as they respond, well, their pain may stay the same, but instead of it bugging them 50% of the day, maybe it's 45%. Again, these are ways that you can measure, and if you are audited, you can point that out to a reviewer. So really important. Qualitative. I have to lay perfectly still to make the pain go away. What do they have to modify to make that pain go away? And these are all things that you can do. And just, again, draw comparisons. Comparable results, these are things that are going to really help you. What makes it better? What makes it worse? Keys to having good documentation. All right? So these are all things that I would include in my subjective notes. Again, objective is the measurable, observable information used from the patient treatment. Instead of just saying edema or just saying trigger points or whatever, what kind, how would you rate the severity of those findings, your palpatory findings? I think those are very important, because then you could say if it was severe one day and now it's moderate to severe, hey, that's improvement. Or maybe you want to judge it on a scale of 1 to 10 or give it a percentage improvement. That's up to you. You don't want to overburden yourself with ratings, but the nice thing about this is when you're doing, remember, you start with the baseline, you do comparisons. If you're just going through and looking at all your positive findings and then drawing a comparison visit to visit, that shortens up the amount you have to write on a daily basis. The toughest part is doing your initial care plan and then, of course, your baseline. Those are going to be the two toughest aspects. Record what you found, and I always recommend citing specific segmental levels when it comes to the spine. Medicare requires it. Other carriers are starting to require it, and even if they don't, the auditors still look for it. So keep this stuff in mind. It's just really easy. If you're going to circle it or whatever, however you're doing it, I would identify the specific levels. And don't just simply repeat positive tests. Sometimes, I see a lot of fluff sometimes out there, and fluff is not good. I mean, I've seen some notes that are 3 pages long for one data service. That's a lot of extra information, and oftentimes what I'll see is that the program, and I don't know if you have one like this, but if you did an initial evaluation, let's say you did some range of motion tests, every visit it will repeat that same test. Even if you're not checking it, it will repeat it. You shouldn't do that because you didn't do that test in subsequent visits. So keep that in mind, that sometimes less is more. And then, of course, each note should be a comparison of the previous one. Not only is it important to do that, but it's also going to help save you time. When it comes to assessment, okay, it's here where you summarize that patient's response, okay? Patient has shown noticeable improvement and so on. You're taking your subjective and objective information and you're summarizing it. Very important to do. Record your diagnosis, and you don't have to write out your diagnosis, of course, in every visit. But in order to qualify for a evaluation and management service and E&M service, the 99 series of codes, you do have to have a diagnosis cited at every exam. So make sure that you write it out. Again, I'm not a big fan of just using the codes. If you want to use both, that's fine, but make sure and have that. And then, of course, identify what stage you're in, passive, active. If you're using Medicare, obviously, Medicare, if you're going to use the AT modifier, active treatment, make sure and identify that for the carrier, or you can say acute or what have you. Be specific when it comes to the plan. Include specific sites and areas treated. And this is where your treatment plan can really save you a lot of time. Remember that template that I suggested that you go in and write out. And if you are specific and you say in week 1 we're going to do this, and week 2 we're going to do that, or maybe you're just doing a week at a time, or whatever the case may be, if you identify what you're going to do, why you're going to do it to, where you're going to do it to, and for how long, then you can simply point to your treatment plan or care plan when it comes to your daily notes. So for example, manual therapy provided 15 minutes as per care plans. You don't have to write out all your goals and rationales for each service because you've already done it on your first or when you did your care plan. Saves you a bunch of time, but it still satisfies that documentation requirement for the specific services. Again, be specific. Don't just say manual therapy, therapeutic exercise, what have you. Short-term goals, time spent. Of course, time is going to be necessary on and in on a visit-by-visit basis. If you're using time-based codes, you must record the minutes spent. You can do it 2 different ways according to Medicare. You can either report the beginning and ending time, or you can report the total time spent for each service, and that's fine. So you're good to go there. If you just document that, then put down, and again, cite your care plan. And you can see just a little sample here. Of course, I might, if I've got a care plan, I'm going to be pointing at that care plan. All right, some other tips that I have for daily notes, and we got about 12 minutes left, so after this we'll go ahead and I'll answer some questions. But all entries must be dated and include the year. I've actually seen where patients have been seen for 3-4 years, and we've got 05, 07. Well, is that May 7th? Or is it of 2007 and the 5th? What? Include the year. I can't tell you how many times I've actually run into that. Include 2 identifiers for the patient for each entry or each page that you have. 2 identifiers. Now, this is a Medicare requirement, but it's going to be what's good for Medicare. And the reason why I like using Medicare as the example is because if you satisfy Medicare's reporting requirements, even though they don't pay you for certain services, you will 9 times or 99% of the time satisfy other payer requirements. So as Medicare goes, so goes most of the other payers, and I think it's a good model to use. Of course, they do have different reimbursement policies, but that's okay. Include 2 identifiers, name, date of birth, name, chart number, whatever the case may be on every page, all right? That's actually a Medicare requirement. And then if you have to make a change or you get a request for records, you cannot change your documentation. If you need to make a correction, you draw a line through it and identify why the change and initial and date that change. If you get a request for records, you're like, oh no, I need to send these in, I've got a travel card, I'm just going to enter them into the EHR and send those in. Don't do that. I actually had a client that did that, and now what that does is that takes the money-only issue and brings up a fraud issue. That is considered altering patient records. It's fraud. That's where you will get an invitation to spend some time in prison. So don't change your records, no matter how bad they are. Start to make the changes now and then move forward. And one other suggestion, if your documentation needs a boost, don't just say, okay, I got to change all of this all at once. Start and take baby steps. You're not going to change everything. Start with a care plan. Start to do your treatment plans, and then even if you're using a travel card, then point to your care plan. I'm telling you, that's 100% better than not having it. And move from there, and then start to work on other things. Also, if you're going to do an EHR system, start to think about it now, because in 1.5 to 2 years, we've got ICD-10 coming down the road. And if you're trying to convert to an EHR system, electronic health record system, and try and deal with ICD-10, probably going to be a little overwhelming. Document everything, missed appointments, vacation. Remember, it's all relevant to the story. If I see a gap in care and I talk to a provider and they say, oh yeah, well they went on vacation. Well, why wouldn't you write that down? Patient went on a month-long trip to Europe. Well, that makes sense. If someone reviewing it it tells the story. So keep that in mind. And then, of course, full signature, strongly recommended. Even electronic health records, you're supposed to sign and lock out each date of service to make it a legal document. Like, for example, the way we do it is we use a PIN, just like an ATM PIN, to sign the note. You plug in the PIN, and boom, it locks that note and says this is now locked and unalterable. So these are all different tips that I strongly recommend when it comes to telling the story and making sure you do it in a compliant fashion. What does all this mean for us and our practices? Well, it actually means less work for daily notes. And you're like, Dave, come on. You just went through all the stuff that I have to start writing down. Well, if we follow, we understand that documentation is a necessary evil. We understand that we have to do it. We have to tell the story. If we follow these steps and create a decent treatment plan and then identify changes from visit to visit, that actually can be less work than having to write a full novel each and every visit. It helps to show the necessity of care, and you will actually get less denials. It's proven. It does work. And then, of course, it can actually result in increased reimbursement if you're billing for everything you do, if you're documenting for it, if you're showing the story and it tells a good story, then I actually find that providers actually will get more reimbursement. They also identify services that maybe they weren't billing for that they should bill for, and so on. So very important, and I really know, it's been proven, I've seen it, you will make more money, you will sleep better at night, and your notes will be what they need to be. All right, well, thank you very much. I appreciate everybody listening. Now what we're going to do is we're going to open this up for some Q&A. Before I do that, just so everybody knows, we were sponsored by PayDC today. That's a company that I work with. They have a complete electronic health record system. If anybody would like more information, or if anybody would like a copy of these slides in hard copy, I will send you a PDF version of this. And you can just email info@paydc.com, and I will send you out a copy of these slides. Now, I have quite a few questions. 2 identifiers, name and date of birth, sufficient? Yes. Name and date of birth, those are 2 identifiers for the patient, and on your notes, okay? I'm not talking on the claim form. I'm talking on your daily notes, so each page should have 2 identifiers. By specific vertebral levels, do you really have to say C1, or can you just say upper cervical spine? Well, for Medicare, you have to say C1. And for also, if you're saying upper cervical spine, and let's say you're doing manual therapy, okay, if you're doing both of those services, you want to make sure and identify the different sites that you're treating. If you just say upper cervical spine and then you're also doing, let's say, the trapezius muscles, they could include, a carrier could say, well, that's included with the upper cervical spine. So the more specific you get, the better chance you have at reimbursement and really backing up what you're doing. So I strongly suggest using the specific segmental levels, okay? Can we use a travel card and then type up the info from the travel code exactly for easier communication? If you get a request for records, okay, and they say, we want to see your notes, you have to identify that you subsequently created that typed record. You cannot use a travel card and then type it in and act as though that typed version were your original records. That would be considered altering patient records, and you could be accused of fraud for that. So what you need to do is if you are going to do that, you need to identify the date that you created that additional record, and I would put a cover letter and say, hey, for clarification, I typed these, the interpretation, just for easier reading, I typed the narrative version of the travel card. Otherwise, you have to identify that, or you could be accused of fraud. The next question is, can you give details on an adequate care plan in which the provider expects resolution of symptoms after one visit, then PRN care? Well, I think that if a patient comes in and they have a complaint, I mean, look, I'm not a clinician, so it's difficult for me to say what would be a legitimate one-visit care plan, but let's say a patient is a young, a 16-year-old kid, strains his back, lifting weights. You go ahead, you give him an adjustment, and then you give him some home exercises to do. You might suggest that you come back as necessary, but that would be an example of what happens. PRN, I don't like using that term PRN, just because I see PRN and the patient comes in on a regular basis, PRN. So what I would say is, instead of stating PRN, I would state come in with any exacerbation of injury or additional injury instead of PRN. It looks better on the notes. It means the same thing essentially, but if that patient does start to come in PRN once a month, that really does look like a form of wellness care. So just keep that in mind. All right, the next question that I have, do treatment plans need to be updated for all patients every 30 days or just for those with third-party payers? Well, you don't have to update it if it doesn't need to be updated. If the patient, you're updating your care plan can say continue on as prescribed. That can be, or as originally planned, that can be the update for the treatment plan. You just want to make sure that you're on the right course, that you're following the plan of care. I see providers create care plans and then never actually follow them or look at them or do anything with them again. So you want to make sure that if you're going to do that, that's fine. Just comment on it. If the patient, if the patient should continue on that plan, go for it. That's fine. The next one is, I do not accept Medicare at my practice. They complete an ABN. Patients choose to come anyway. However, office told me I had to submit claims or paperwork anyway. Would that be correct procedure? So you're seeing a patient, a Medicare patient. You don't accept it. You have to be careful about this. Number one, there's fee rules. There's a limiting charge that you can charge the patient only, and you cannot go above that. The second thing is, if you're going to have them sign the ABN form, they would have to say, don't send in to the carrier. I would, this question, I might need you to shoot me an email on that. If you can shoot me an email on that, and we can set up a call, because that might go a little bit, might be a little more in depth than we need to. But I want to go through it. You just want to be careful about Medicare. If a patient requests that you send in the claims, then you must do that. I've actually personally experienced that. We weren't sending in the claims. The one patient wanted us to, contacted Medicare. Medicare called us, said we have two options. We can either submit the claims for that patient, or we could be audited. And we, of course, chose to send in those claims. So you want to make sure and follow that. Okay, next question. I've got time for one or two more. If a treatment plan specifies specific therapy, for example, ultrasound at a particular wattage at a certain location for a set amount of time in the daily notes, would we have to specify anything but ultrasound performed that day, intensity, location, and so on? So basically what they're saying is, yes, if you specify the wattage and everything, you can point to that treatment plan. The only thing that I would do, because each visit, when you record time, that's face-to-face time. It is not necessarily the time that you actually apply the ultrasound, but you have to put the gel on, you got to set up the patient, and so on. So you need to record the minutes spent at each and every visit. But as far as the wattage and all that, if it's set, you can point to that. Absolutely, that's fine. Okay. The next question, if you treat a patient actively for 12 visits, then switch them to supportive care, as long as your care plan outlines the goals of active, and when the switch occurs to supportive care, are 6 to 12-month care plan going to cause alarm, especially if insurance only pays for the 4 weeks? No, I think that's fine. I mean, I personally like separating my different types of care plans, meaning I've got acute. If I'm planning on getting paid by a carrier, it's going to be an acute care plan. Supportive and wellness type care plans, yes, I think they're fine if you want to kind of combine them and have them identified as different stages. I think that's okay. Just make sure that you are very clear on that, and that if they review it, that they see that, hey, we identified and we stopped submitting claims during that time. So I think it's fine. For me, I like having everything separated. I got time for one more question. Is it a reasonable goal to have short-term, such as 50% improvement in back index score? Yeah, I think that's fine. I mean, 50% improvement, that is, it depends on what kind of time frame you're talking about. Maybe you want to shoot for something more like 20% improvement so you have more room for error, but that's up to you. If you want to do that, that's fine. 50% improvement over a 2-week period of time, I think that can be. And that, I still would consider that almost a longer-term goal, but if you can assign it to a particular service, because that really is going to deal with all of your services. So short-term goals I assign to specific services. Long-term goals, such as 50% improvement over the next 2 weeks, I would still consider that probably a long-term goal. But that's a good question. All right, everybody. Thank you again to the NCCA for inviting me and all that attended. Thank you, Heather, and thank you,